The purpose of this short talk is to highlight in brief the 10 key steps to performing a basal first metatarsal osteotomy successfully, and it should be watched in conjunction with reading the OrthOracle Surgical technique. There are many more steps, of course, to the procedure than 10, and a familiarity with Hallux Valgus exposure and anatomy is assumed as a starting point in all of this. The complete detail that you need is on the OrthOracle platform, and this talk is based on the information there. As always, rely on the manufacturer's technical advice on how to use their implants, and there are of course other basal plates that do a similar job to the one detailed, though I rely on the Arthrex versions, having used a number of different manufacturers' plates. This is simply a description of what works for me for this operative technique. In terms of case selection in my practice, I use a basal osteotomy just for a severe deformity, though it is clinically indicated also for moderate Hallux valgus. The Arthrex implants do support lesser degrees of correction with smaller opening wedge plates. What is severe is defined objectively by the measurement primarily of the intermetatarsal angle, this being greater than 18 degrees, and a Hallux valgus angle of greater than 40 degrees. Personally, I don't find the measurement of the Hallux valgus angle of any use in assessing the deformity in relation to surgical decision making. My one exception, though, to the deformity needing to be severe for a basal is if the patient has a bilateral deformity, one severe and one moderate. If you don't use a basal on both, corrected though the feet will be, there will be a different shape to each other if one is corrected with a diaphyseal osteotomy, like a scarf, and the other using a basal. This may or may not cause complaint, but symmetry can be kept if both sides have a basal performed. In assessing the patients, clinically the things to take particular note of are the weight-bearing appearance of the foot and the shape of the whole foot should be noted. A pes planus with increased medial column loading in particular will accentuate a Hallux valgus deformity. On this issue, another key point is the patient needs to be absolutely weight-bearing in making the determination of whether deformity is severe, and that's both visually during examination and also when taking x-rays of the deformity. The range of movement of the first MTP joint should be carefully assessed. Restriction may indicate osteoarthritis and change your choice of operation. Equally though, it may result from the joint geometry being incongruent with normal non-arthritic surfaces. The ease of correctability of the deformity is also worth noting clinically. A flexible and fully correctable deformity in the examination room will be an easier case surgically, definitely. However, always be wary of the highly flexible and severe deformity, which will be overcorrectable easily and can lead to a hallux varus post-surgically. The mobility of the first tarsometatarsal joint should also be noted, and if very mobile, a lapidus should be considered as an alternative procedure. In terms of the radiographic assessment, the intermetatarsal angle is how one determines whether a deformity is severe, but this is not an absolute determinant of whether a deformity is severe. To explain, this is because of the effect of a varus-aligned second metatarsal in reducing the intermetatarsal angle. In other words, the first metatarsal can be severely medially deviated, but the IM angle does not correlate with the severe deformity because the second metatarsal has also moved into varus, reducing the measured gap. Clinically, though, the deformity will still look severe, even with a varus second metatarsal affecting the X-ray measurement. The moral is go with your clinical assessment, and if the weight-bearing appearance is severe, that's what it is. That's something, though, that just comes with experience. Osteoarthritis should definitely be looked for, both at the MTP and also the TMT joints. It can be difficult to see with plain X-rays in both areas. At the MTP, it can be difficult to be certain of because of incongruency, which is more common with the larger deformities, and at the TMT joint, it can be difficult to see because of joint anatomy. On the X-rays, you should look at the sesamoids. If both sesamoids are uncovered or largely uncovered by the metatarsal head, that's a good rule of thumb to define a severe deformity by. And you should also get an idea of the distal metatarsal articular angle, which will always worsen if you're using an opening wedge and is itself a deforming force. It's common, therefore, to need a distal osteotomy, either metatarsal or phalangeal, as well as the capsular closure with an opening wedge. Alternatives to the operation are various. An excellent and comparable result with an easier post-operative course is probably a corrective fusion of the first MTP joint, often combined with a lateral release, which can achieve a full correction of deformity, but it will require a stabilising plate. A more direct approach in the same anatomical vicinity as the basal is the lapidus corrective fusion of the TMT. Traditionally, this type of operation has as a risk non-union. Newer nailing and plating techniques are addressing these issues. But the lapidus still requires distal work around the MTP joint, as would be the case with the basal. In terms of the surgical skills that you need for the case, a severe deformity is less common than a moderate deformity, and it's more difficult to succeed, so it shouldn't be your first case. You'll need a general familiarity with Hallux Valgus corrective techniques, and specifically, you'll need to do a lateral release, an Aitken or a distal metatarsal osteotomy, and you'll need a good capsular reefing technique, and possibly even be happy to fractionally lengthen the EHL tendon. In terms of the surgical exposure, you'll need a long incision unless you're using an MIS technique, and that runs from the TMT to the mid part of the proximal phalanx. You can use 2 incisions, which are slightly shorter in overall length, but it often isn't really worth the effort in making 2 separate incisions. There are a couple of points specific to the lateral release when performed with the basal for severe deformity. First, be careful with the EHL superiorly. It can sit way off lateral in a first metatarsal severe deformity, so don't cut it during the lateral release. And secondly, the lateral sesamoid may be very displaced and jammed up the lateral side of the metatarsal head, not sitting plantar at all, which can disorientate you when you're doing your access for the modified McBrides. Removing the exostosis does not have to be any more significant than for a standard Hallux Valgus procedure, and I'd suggest leaving a small plantar buttress of bone to buttress the tibial sesamoid. It reasons, I think, that this would reduce the chance of developing a hallux varus deformity. You shouldn't be taking any more bone than for any other type of hallux valgus correction. The location of the osteotomy is at the junction of the metaphyseal flare and the diaphysis. It's straightforward to identify this point visually with a sub-periosteal exposure. It's key to leave enough bone on the proximal side of the osteotomy so as not to breach the TMT joint with a basal plate fixation. I have my implant ready, chosen, so when I cut, I'm offering the implant to the bone and I can mark exactly where the cut is. To ensure there's enough space for fixation. 5, 6 and 7mm plates are the common sizes required. The technique of the osteotomy is key, and primarily don't cut all the way through the metatarsal, and secondarily cut strictly at right angles to the long axis of the metatarsal. Once I'm visually about 50% across, I frequently remove the saw and test with an osteotome in the gap to see how mobile the osteotomy is. Cutting all the way through or fracturing all the way through subsequently makes fixation a whole lot more fiddly and time consuming than it needs to be. The saw blade needs occasionally angling superior and inferior to ensure the cortex is uniformly cut. Once there are just a few millimetres of movement is when to insert stepwise the 3 osteotomes, and after each one has been fully tapped home, again test the movement. It will take all 3 inserted to get adequate mobility of the osteotomy. There is a distractor supplied to open the osteotomy, but the issue is being able to insert a plate exactly where you want it with the distractor sitting in the osteotomy, so I tend not to use it. I've rarely found an issue with instead using the lever arm principle of opening the osteotomy by using distal valgus pressure applied to the hallux and to the metatarsal head. Once you've got a mobile osteotomy, it's key that you have all you need set up and ready to go and immediately to hand. The osteotomy takes a little effort to hold open enough to get the plate in, and having the locking guide screwed into the plate also helps manoeuvring the plate into the gap you've created. The plate, once implanted, should not be prominent dorsally, and you should also ensure the osteotomy does not dorsiflex at any stage, which will defunction the first ray if you don't notice this drift. Don't fix the metatarsal into dorsiflexion. Once the plate is well seated, you should keep it in place with manual pressure and not let that up until you've a screw on both sides of the plate, fixing its position. The exostosis is usually enough bone to pack into the gap created by the open wedge. The osteotomy being in metaphyseal bone, it tends to heal well. Balancing distally, you'll be left with a big distal pocket of skin, and that confirms the size of the completed shift. The skin can and should be comprehensively removed, taking care inferiorly as you'll come close to the plantar nerve. The dorsal skin is very mobile and is advanced into the gap created easily. The opening wedge will always worsen the distal metatarsal angle, which increases the valgus tendency at the joint. So in almost all cases, further surgery is required than simply a capsular closure. And that shouldn't come as a surprise if you're doing this operation. You should expect it, you should plan for it. First, place a single capsular tightening suture and assess the tracking and stability of the joint. Once the tendons are centralised to the MTP joint or close to centralised, the MTP joint is stable and tracks normally, but this is a very rare occurrence after the basal alone. To rebalance the pull of the tendons, either an Aitken osteotomy or distal metatarsal osteotomy is needed. Personally, I always use a generous Aitken. On occasion, this is not enough to allow a stable reduction of the joint, and if so, there will likely be a very tight EHL that needs careful fractional lengthening and then careful post-operative support. For my comprehensive step-by-step surgical guide, as well as access to full papers and an accredited CPD module on the basal osteotomy, the brides, the Aitken, the technical tips of Hallux Valgus closure and other corrections for Hallux Valgus, visit us at OrthOracle.